Hello, my name is Dr. Mary Frates. I am from Brigham and Women's Hospital in Boston, Massachusetts, where I'm the Assistant Director of the Ultrasound Division, and I'll be speaking today on ectopic pregnancy. I have no financial relationships to disclose. The learning objectives for this talk include the ability to identify the most common sonographic appearances of ectopic pregnancy, also to classify the various types of ectopic pregnancy and describe how to differentiate each type, and to list a variety of sonographic techniques that can be used to assist in the diagnosis of ectopic pregnancy. In terms of an outline for the talk, we'll start with a background or initial evaluation of the patient, review the sonographic findings in the uterus and the adnexa, speak a little bit about diagnosing tubal rupture, and finish up with the role of 3D imaging for unusual forms of ectopic pregnancy. Starting with the background, we know that ectopic pregnancy means that the products of conception have implanted somewhere outside of the endometrial cavity. And this is reported to occur somewhere between 1.5% to 2% of pregnancies. We also know that complications of ectopic pregnancy remain the leading cause of pregnancy-related deaths during the first trimester in the United States. So this is a critically important diagnosis for us as imagers to be able to make. 95% of ectopic pregnancies occur in the fallopian tube. The most common location for these ectopics is the ampullary segment of the tube, or the distal end of the tube, where 90% occur. A smaller number, about 10%, occur in the isthmic portion of the tube, and an even smaller number are interstitial, sometimes misdiagnosed as cornual pregnancies, in this portion of the tube, which is in the intramural section of the uterus. An extremely small number of ectopics can be implanted in the ovary or in the cervix, and implantation in a cesarean section scar site is of unknown percentage, but probably increasing as the rate of cesarean section in the United States continues to increase. Risk factors for ectopic pregnancy include any patient who has tubal scarring. This could be from pelvic inflammatory disease, a previous ectopic pregnancy on one side, endometriosis, really any cause for the tube to be scarred. Patients who have an indwelling intrauterine contraceptive device, an IUD, are at increased risk for ectopic pregnancy. And any patient undergoing assisted fertilization to attempt to conceive is at increased risk. Remember that 25% of pregnancies that happen in patients who have an IUD or who have had a tubal ligation will be ectopic in location. So if there's a patient coming in post-tubal ligation or with an IUD in place and a positive pregnancy test, you really are going to be very highly suspicious that you may find an ectopic. Having said that, 50% of patients with the final diagnosis of ectopic pregnancy have no known risk factor. Here's a few examples of a hydrosalpinx, and by definition, a hydrosalpinx is an obstructed tube, and we can see the fluid-filled tubular structure posterior to the uterus here. And in this image, again, the tubular structure with a bend in it here. You can see the wall of the fallopian tube. This is a classic hydrosalpinx, and a transverse image of a hydrosalpinx, not as distended as the other two images, where you see that cogwheel appearance on the transverse image. The classic presentation of a patient with ectopic pregnancy is the clinical triad of a pain, vaginal bleeding, and a palpable adnexal mass. Clearly, we'd like to see a positive pregnancy test before we start evaluating for ectopic pregnancy, and then we move to an ultrasound. And here you have an image of a classic tubal ring seen medial to the left ovary in a patient with ectopic pregnancy. Let's talk a few minutes about the pregnancy test. Trophoblastic tissue starts making HCG 8 days after conception. With a normal pregnancy, we can typically see an intrauterine gestational sac once the HCG reaches 1,000 milli-international units per ml. However, you should be aware of a study from 1997 in which 17 of 51, or 33% of patients with an HCG over 2,000 who were followed and not treated for ectopic pregnancy eventually developed intrauterine pregnancies. This is a report of some data from Brigham and Women's Hospital where we looked at the HCG that was measured within 24 hours of an ultrasound in 225 patients with proven ectopic pregnancy. In these patients, the range of HCG levels went from 7 to a high of 107,949. The average HCG level in our patient population with ectopic pregnancy was 3,256. We also noted that the HCG was significantly higher in patients who had positive cardiac activity in the ectopic pregnancy as compared to patients with no heartbeat seen in the ectopic, with a number of almost 21,000 in the patients with a heartbeat versus less than 2,000 in patients with no FH. Interestingly, over 3/4 of our patients had HCG levels under 3,000, but 7% had HCGs over 10,000. I'll also remind you or mention to you of a cautionary case that we did see at the Brigham recently. This was a patient who came in with an HCG measuring over 4,000 with nothing in her uterus and nothing in the adnexa. We did not treat the patient. We brought her back for a follow-up ultrasound, and on the follow-up exam, there was a normal intrauterine gestation. So the important point to remember here is that it is incorrect to please do not diagnose or treat for an ectopic pregnancy if you're looking at a stable patient until you're 100% certain that the patient has an ectopic and not an intrauterine pregnancy. So what do we do with that patient with a positive pregnancy test and nothing in the uterus? This is what we term pregnancy of unknown location. In these patients, there really is only 3 options for what could be going on. 1, the patient could have a very early intrauterine pregnancy, which is too early for us to see because we don't pick them up on ultrasound until 5 weeks. 2, this could be a failed pregnancy, a spontaneous abortion that either has just happened, is about to happen, or even a chemical pregnancy. Or the third option, we're looking at a patient with an ectopic pregnancy. Well, let's go back and talk about how you make the diagnosis of an intrauterine pregnancy. With an intrauterine pregnancy, an intrauterine gestational sac is round, has a discrete echogenic rim, and if you're lucky, and the diagnosis is going to be very straightforward, the sac will contain a yolk sac, a fetal pole, or even cardiac activity, a fetal heartbeat. Remember that the intrauterine gestational sac should be located within the decidua of the uterus. Do not be misled by complex fluid in the endometrial cavity. Here's a few examples of the intradecidual location of an early gestational sac. Here's the gestational sac. It's well-defined, round, anechoic center, nice bright white ring around it, and notice that this gestational sac is clearly implanted into the thickened decidualized endometrium. And we know that because we have fluid in the endometrial cavity that's outlining the gestational sac. It's a little bit more difficult in this case, but again, you can see the thick decidualized endometrium and a well-defined fluid collection in the center of the decidualized reactive endometrium. Again, a smaller sac, tiny fluid collection. The white ring is not as clear to see here, but is absolutely located within the decidualized endometrium. In any of these cases, you can read this out as either a small gestational sac in the uterus or a probable gestational sac in the uterus. Another case, you can see the well-defined echogenic rim around the nice round discrete fluid collection, and in this case the fluid in the endometrial cavity is lifting up this irregularly thickened decidualized endometrium anteriorly, and we have fluid tracking posteriorly. Contrast that to these 3 cases where no real gestational sac is seen. We see the decidualized endometrium that is split by a small amount of complex fluid. Again here, a small amount of complex fluid, but this time with debris dividing out or filling the endometrial cavity, and we see the decidualized endometrium pushed out to the side. And again here, irregular complex fluid splitting the decidualized endometrium, but no fluid collections buried in or burrowed into the decidualized endometrium. There is no gestational sac present in any of these cases. This is simply complex fluid in the endometrial cavity. Well, maybe we could look at the endometrium and determine whether an intrauterine pregnancy is present based on the thickness of the endometrium. In 2008, Moskos et al. Looked at this and found that no intrauterine pregnancy had an endometrium of under 8 millimeters. However, they did have 4 ectopic pregnancy patients who had an endometrial thickness of greater than 25 millimeters. So endometrial thickness is a little bit helpful, but not good enough. What about a trilaminar pattern? Well, Archives of GYN and Obstetrics in 2010, a paper looked at whether the trilaminar pattern of the endometrium is more frequent in patients with ectopic pregnancy as compared to patients with intrauterine gestational sacs. Is this any good? Not really. It did have a specificity as high as 93%, but a positive predictive value of only 50% and a quite low sensitivity for ectopic pregnancy. Here's a recent case that we saw at the hospital. This is a 30-year-old patient who was taking Clomid to attempt to get pregnant. And based on her last menstrual period, she should be 7.5 weeks pregnant with a positive pregnancy test, and came into one of our outside offices where the study was read as negative for an intrauterine pregnancy. You could see the decidualized endometrium here, and here's a picture of the right ovary read as normal. However, this is the picture they sent of, another picture they sent of the right ovary, and it just looked a little bit too big. A little bit different from here. This is another image of the right ovary, and you think, wow, how could that be the same ovary? So we asked the patient to come into the hospital to repeat the study that afternoon. And we found that indeed this right ovary was extremely large, and if you look, there's actually a mass on the edge of it. And with a clip, we can see with real-time imaging that this is an ectopic pregnancy adherent to the edge of the right ovary, and here's the heartbeat of the 7.5-week embryo. Okay, so it turns out that ectopic pregnancies are better diagnosed by finding an adnexal mass rather than not finding an intrauterine gestational sac. Once you find the mass, then you can be quite confident that you're looking at an ectopic pregnancy, and then you can begin treatment for that ectopic without concern for harm to an intrauterine gestational sac. Here's a patient who presented with a history of prior ectopic pregnancy. And she's only 4.7 weeks pregnant, but she was having some pelvic pain and knew she had had a prior ectopic, and so came in for an ultrasound. And we found a normal appearing right ovary here. And normal, however, next to the ovary, here's the normal ovary, we found this solid appearing mass with a little bit of color flow in it. On the video clip, you can see the ovary passing by, and yet this solid tissue running along the edge of the ovary. However, she's only 4.7 weeks, no focal mass. This seemed to be a long tubular soft tissue mass, and indeed what we're seeing here is the normal fallopian tube. As our equipment gets better and better, we are able to identify the fallopian tube along the edge of the broad ligament in healthy patients who have no pathology in the tube. So we watched this patient, and at follow-up, she developed a normal intrauterine pregnancy by 5 weeks. Well, what are we looking for when we go out to the adnexa? The thing that we would like to see is a tubal ring. A tubal ring can be thought about as the gestational sac that instead of being in the uterus is out in the adnexa. So we see an anechoic center and a bright echogenic ring. And it literally, in your mind, you should think about it as looking exactly like what your IUP looks like, except sitting next to the ovary instead of sitting in the decidualized endometrium. In a recent study of ectopic pregnancies that we looked at with 231 ectopics, 25% of our patients had a tubal ring found in the adnexa. Another 8% had a yolk sac within the center of that tubal ring, and another 7% had cardiac activity in addition to the yolk sac within the adnexal ring. Well, what do I mean by an adnexal ring? Here's the normal right ovary, and here's the adnexal ring. You can see it looks just like an intrauterine gestational sac. Here's the yolk sac, and when we zoom up on it, here's the embryo and the cardiac activity. This looks just like an intrauterine gestational sac. Indeed, it is a gestational sac. It just landed in the wrong spot. Here's a patient this is the coronal image of the uterus, and this patient has an intrauterine gestational sac. You can see the echogenic ring. You can see the yolk sac in the center. However, in the left adnexa is an almost identical appearance of the ectopic pregnancy with the trophoblastic bright ring and the central gestational sac. So this patient indeed has a heterotopic pregnancy with the intrauterine pregnancy here in the uterus and the extrauterine ectopic seen in the left adnexa here. But these are incredibly similar appearances of the intra and extrauterine pregnancies. The mass of an ectopic pregnancy can be incredibly subtle. This is the edge of the uterus here and the right ovary here, and a little tiny white ring with nothing in the center of it right now, measured here and turning sagittally on it a little bit larger and more impressive in the sagittal plane, but very, very subtle in the coronal plane. So it's not going to jump out at you, but you have to look very, very carefully when you haven't found an intrauterine pregnancy. However, an adnexal ring is only found, as we saw, in about 40% of ectopic pregnancies. The majority of patients with ectopic pregnancy, 55% in our recent series, present with a complex mass with poorly defined borders. Now, when you see these complex masses, it typically is clot. And if you look hard or very carefully in the center of the complex mass, you may be able to find the adnexal ring right in the center because, again, this adnexal ring is now surrounded by large amounts of blood. You need to remember that most ectopic pregnancies are located within the fallopian tube, and in essence what you're seeing is blood filling the center of the tube or creating a hydrosalpinx, and that's what you should be looking for or trying to create when you're examining the adnexa. Here's a patient with a typical complex adnexal mass. We can see the right ovary here and the uterus here, and this 2 centimeter solid mass between the ovary and the uterus in a 5.7 week patient, highly suspicious for ectopic pregnancy if there is nothing in the uterus. Here's a different patient where you see the normal ovary sliding off here. This is the right ovary. And then medial to the ovary, we see a more tubular appearing complex mass. And if you look carefully at this tubular mass, you notice that there's a white ring in the center of it. And that's the tubal ring located within the hematosalpinx. If you look closely at this ring, you can see on this clip that we actually have a twin ectopic pregnancy with 2 gestational sacs closely adherent to one another in the center of the fallopian tube. Here's an older case, but it shows us a little bit more clearly what actually is happening with an ectopic pregnancy. So we have this complex mass in the adnexa, and within the center of the mass, the echogenic ring. Turning coronally on the mass, you identify a larger ring-like structure with the central adnexal ring. So this is the pregnancy, and this is the distended fallopian tube. The pregnancy has attached to the wall of the tube and caused bleeding when it attached, and there is blood filling the center of the tube, creating a hydrosalpinx. And of course, when that blood goes out the fimbriated end of the tube, we get a hemoperitoneum, which we're seeing out here. So we have the wall of the fallopian tube outlined by blood on the inside and blood on the outside. Now, the landmark study in evaluation of the adnexa in patients with ectopic pregnancy was done by Brown and Duboulet and published in 1994. This was a meta-analysis of 10 large studies, making an attempt to determine the most appropriate criteria to diagnose an ectopic pregnancy. And what this study found that any non-cystic extraovarian adnexal mass had a very high likelihood of being an ectopic pregnancy. And take those words carefully and separately. So, non-cystic. We are not talking about ovarian cysts. We are not talking about para-ovarian cysts. The lesion of an ectopic pregnancy is not a simple cyst. Next word, extraovarian. A lesion that is on the ovary or part of the ovary is highly unlikely to be an ectopic pregnancy. We're looking for masses that are not on the ovary and not simple cysts. And when you have that non-cystic extraovarian mass, the specificity for ectopic pregnancy is 99%, sensitivity 84%, and a positive predictive value of very high 96.3%. Well, a similar study was done in 2005 by Kondos et al. And they looked at, again, a non-cystic, non-ovarian mass and found an even higher specificity as ultrasound equipment improves of 99.9%. Again, positive predictive value well over 90%. So here is again what we're looking for. Here's the right ovary. Here is this non-cystic, non-ovarian adnexal mass sitting medial to the ovary. This is highly likely to be an ectopic pregnancy. But remember, look carefully at it and see if you can get it to move away from the ovary, or see if you can find a gestational sac within the center of it. Also note the adjacent complex free fluid, which is an important identifying factor in a patient with ectopic pregnancy. So when you do this, if you look at this clip carefully, you can watch the clip play and at the very end see if you notice anything. Because when I freeze the probe at the very end, or freeze the image at the very end, we see a little tiny gestational sac in the center of this big echogenic structure. Again, you'll look for it. It is right here. So once you see these big masses, scan them carefully, look for your ring right in the middle of the mass. Another patient with an unusual mass in the left adnexa this time. Here's the normal left ovary. Here's the uterus here. And here's this somewhat unusual looking mass. Very sharp margins between this echogenic center and the hypoechoic rim. When we look at this in another plane and scan slowly through the mass, we see that what we're looking at, again, normal left ovary back here, is the tube. This is the distended hematosalpinx, a long tubular structure, complex fluid in the center of the hydrosalpinx at this end, and the echogenic trophoblast filling the lumen of the fallopian tube at this end. Again, complex free fluid giving us the triad of echogenic mass in a tubular structure with complex free fluid likely representing blood.
Okay, can I just your microphone? Got a little twisted under it. There you go. There you go.
Oh.
Is that good?
Yeah.
I'll put it on this side if you want.
No, that's okay. I'll just try not to touch it.
Okay, no problem. Thank you. Whenever you're ready.
Now, things to consider when you think you have found an adnexal mass. First, can the mass be separated from the ovary? Could you possibly be looking at a corpus luteum on the ovary, or can you somehow separate this mass away and know that it's an extra-ovarian mass? And also, and I'll get into this in a little bit, what is the echotexture of the mass? So what do I mean by movement of the mass? When you're scanning transvaginally, one hand is on the probe, pushing from inferiorly, and the other hand should go onto the patient's anterior abdominal wall, pelvic wall, and push against the probe so that the mass is held between your two hands, and see if with some motion of your hand or motion of the probe, the mass can be slid in one direction and the ovary in another direction. So when we push on this patient, the ovary stays pretty still, and the ectopic pregnancy can be slid away, and you can see the motion between your splitting those two planes between the ectopic and the ovary. In contrast to this patient, when we push on this complex mass next to the ovary or on the ovary, we cannot split it off. There is no way to pull this off the ovary because it's part of the ovary, because it's the corpus luteum. When Blavet et al. Looked at movement of an adnexal mass in JUM in 2005, they found that 21 of 23 patients with an ectopic pregnancy they were able to show movement of the mass with palpation on the anterior wall. 6 of their patients without ectopic also showed movement of the mass with palpation, giving them a negative predictive value of 96 and a positive predictive value of about 78%. Here's a patient with an empty uterus, nothing in the uterus. Here's the ovary, here's the mass, and again with motion, you can see the ovary moves laterally and the mass spins. It doesn't necessarily move away, but it's moving differently from the ovary, independently from the ovary. Here's a different thing to consider when you're looking at adnexal masses for possible ectopic pregnancies. And this is a little bit of an old case, but this is where the thought, I first appreciated the concept that I'm going to share here. This is a patient who had undergone infertility workup and conceived a pregnancy, but continued to have pain in her pelvis, and went to have an ultrasound at another hospital in the city, and was told everything was fine. There was an intrauterine pregnancy, it was right on time, there was nothing to worry about. But she was still having pain, so after about 48 hours came to the Brigham and asked to be evaluated. So we did another ultrasound on her, and we can see certainly an intrauterine gestational sac. And within that sac, I don't know if you can appreciate, there's at least one and possibly two yolk sacs. So we're clear we have an intrauterine gestational sac. We may even have an early twin gestation. But notice there's a lot of complex fluid around the outside of the uterus. Over in her right adnexa was a very large heterogeneous mass. Really could not figure out whether this was the ovary or not. I just had a very large mass, and I thought, wow, how am I going to, the ovary has to be in there somewhere. How am I going to find it? I could find two round structures, this hypoechoic ring and this more echogenic process. Turned on color Doppler, and you can see this, again, this hypoechoic ring has the ring of fire around it that we typically see with a corpus luteum, and a little bit of flow around the echogenic mass, but not the dramatic flow that you see in a corpus luteum. So we knew that this is the corpus luteum in the ovary, and this, seen here, is almost certainly a right-sided ectopic pregnancy. She was taken to the operating room, did indeed have a right-sided ectopic pregnancy and an intrauterine gestation, and blood completely encasing the right ovary. So what this case brings up is whether we can use sonographic characteristics to differentiate between the tubal ring and the corpus luteum. We took a look at this a few years ago at the Brigham, and we compared patients with tubal rings to patients with intrauterine pregnancies and the corpus luteum. And what we found was that 88% of our tubal rings that had yolk sacs or heartbeats were more echogenic than the ovarian parenchyma. 77% of patients with empty tubal rings, the rings were more echogenic than the ovary. And in our 45 control patients with intrauterine pregnancies and a corpus luteum, the corpus luteum was more echogenic than the ovary in only 3%. So the tubal rings are brighter than the ovarian parenchyma, and the corpus luteum is more hypoechoic than the ovarian parenchyma. Here's an example of what I mean. You can see in the image on the left side of your screen that the normal ovary is here. Here's the tubal ring, and when you compare the margins of the tubal ring to the ovary, the tubal ring is much more echogenic than the ovarian parenchyma. In contrast, here's the corpus luteum in a different patient, and you compare the wall of the corpus luteum to the ovarian parenchyma, and the corpus luteum is much more hypoechoic than the ovary. So remember, the relative echogenicity of a tubal ring is a useful differentiating characteristic between tubal rings and corpora lutea when you can't completely localize where the ring is. Well, another group, Stein et al., took another look at this, and they compared the corpus luteum and the ectopic pregnancy to the echogenicity of the endometrium. And they found that the wall of an ectopic pregnancy was brighter than the endometrium in about a third of their patients with ectopic, but in none of the corpus luteum patients. The wall was less echogenic than the endometrium, again in about a third of their ectopics, but in the majority of the corpus luteum. Another case to realize that there's an exception to every rule. Here's a study that was done overnight. One of our residents saw the patient in the emergency room with pain, an adnexal mass, and vaginal bleeding. And in the uterus found this intrauterine gestational sac, and there is a yolk sac, and we can see a heart rate of 106 seen on this M-mode tracing, even though you don't see the embryo on this image. But in the adnexa, the resident identified this discrete mass with an echogenic ring and a fluid-filled center, and diagnosed the patient with ectopic pregnancy. This patient was taken to the operating room, and an ectopic pregnancy was not found. And I'll point out a few reasons why an ectopic pregnancy was not found. despite the fact that this ring is indeed more echogenic than the ovarian parenchyma. If you look carefully at the edge of the ovary, you can see that the ovary continues all the way out here. And this is clearly an intra-ovarian lesion. Here's the image from the operating room. We can see the normal ovary here and the bulging corpus luteum seen on the top edge of the ovary, and no ectopic pregnancy was present. So don't rely solely on echogenicity of the ring, and don't rely solely on location of the ectopic. Use both or the location of the mass, use both to make your decision about whether it's an ectopic or a normal finding. Another way to distinguish a tubal ring from a corpus luteum might be the use of color or pulse Doppler. Atri and al. In 2003 suggested that Doppler characteristics could be used to distinguish between an ectopic pregnancy and a corpus luteum. The ectopic pregnancy RIs ranging from 0.15 to 1.6, whereas the corpus luteum RIs much narrower window between 0.39 and 0.70. An RI of over 0.7 was 100% specific for the diagnosis of ectopic pregnancy and had a positive predictive value of 100%. But it was only found in 1/3 of the ectopics. Another way to look for an ectopic pregnancy is to look for the presence of free fluid. Was that reliable? Well, if you can look at the fluid, if you do have a patient with free fluid, make sure you analyze it to see if it's anechoic or echogenic. Fluid with echoes in it correlates with hemoperitoneum at a very high rate and suggests patients are at high risk for ectopic pregnancy. In a study from 1998 by Sickler, they sent 185 patients to the operating room for the diagnosis of ectopic pregnancy. They had 125 patients with echogenic fluid in the pelvis, and over 98% of those patients had blood at surgery. In 30 patients with anechoic fluid in the pelvis, 0 had blood. And in 30 patients with no fluid in the pelvis, 0 had blood. So we do know, again, that echogenic fluid correlates highly with hemoperitoneum. In another study more recently in the American Journal of Emergency Medicine, Dart et al. Had 38 patients out of their 523 pregnancy of unknown location patients who had isolated free fluid. And so it turned out that almost half of those 38 patients ended up with an ectopic pregnancy. In patients with moderate fluid, 22% had an ectopic. But in patients with large amounts of free fluid, 73% had an ectopic. So patients who have isolated cul-de-sac fluid with no adnexal mass identified are at moderate risk for an ectopic pregnancy, and the risk increases if the fluid is echogenic or if the amount of fluid is large. Here's a patient who came in to the Brigham with 5.4 weeks very solid dating and a positive pregnancy test, but an HCG of only 35. The uterus was empty, but at ultrasound we found complex fluid in the left adnexa and a large amount of complex fluid in the cul-de-sac. Patient was hemodynamically stable, not having any pain, so a Carmen biopsy was done to look for villi in the uterus. The Carmen was negative, the patient remained stable, and over the next week her HCG dropped to 0 with no intervention. So this patient likely had what's known as a tubal abortion. This is what occurs when a pregnancy is located in the fallopian tube, and instead of an intrauterine pregnancy miscarrying out the cervix with a large amount of blood, in a tubal abortion, an ectopic pregnancy miscarries out the fimbriated end of the fallopian tube with associated moderate to large amounts of bleeding, but with no intervention necessary. The pregnancy tissue simply reabsorbs in the peritoneal cavity. What about a negative exam? What about the patient who has no ectopic found, no intrauterine pregnancy found? What could the explanations be? Well, one is that it's a very early gestational age and there's an ectopic out in the fallopian tube, but just as we can't see an intrauterine gestational sac before 5 weeks, we won't be able to see all ectopics before 5 weeks as well. Patients with a high BMI, fibroids, ovarian pathology, all of those things could obscure an adnexal mass, and inexperience of the examiner is of concern as well. We had 5% of the patients in our series of proven ectopic pregnancies with a completely negative ultrasound. What should you do with that patient? Well, if the patient is clinically stable, the most appropriate management is to follow the HCG and follow the ultrasound. Because at that point, with a negative exam, you do not know if you're dealing with an intrauterine pregnancy, normal or abnormal, or an ectopic. These patients should not be treated until the diagnosis is confirmed. In contrast, if the patient is unstable, if the patient is hemodynamically unstable, that patient needs to go to the operating room regardless of where the pregnancy is. So you don't have to worry too much about what do we do. If your patient is stable, you're just going to watch her. Here's a patient who came in following assisted fertilization with several large cysts on her right ovary and a small amount of free fluid in the cul-de-sac. Clinically stable, and I was very concerned that maybe she was torsing her ovary because she was having adnexal pain. So we took a lot of pictures on the right ovary. And unfortunately, we're not able to see the problem. Someone watching this may be able to spot the problem, which in retrospect, when we went back and looked, we were able to find. So I sent the patient to the operating room for a torsed ovary. But if you look closely on this clip at this area right here, and I'll zoom that up for you, there is a gestational sac, an adnexal ring with a yolk sac, an embryo, and a heartbeat stuck on the edge of that right ovary. And the ovary was not torsed. This patient had an ovarian ectopic. Well, let's move to a new topic now and discuss the diagnosis of fallopian tube rupture in the presence of an ectopic pregnancy. Why do we care about it? Well, there is an increasing trend towards medical management of ectopic pregnancies. And if a patient is going to be managed with methotrexate or with watchful waiting, an intact fallopian tube is required. So it's important to know whether transvaginal sonography can tell us what the tubal status is. We did a retrospective study looking at ectopic pregnancies proven at surgery in patients who had transvaginal sonography within 24 hours before surgery back in 2014. In this study, we had 143 patients who went to the OR. Of these, 107 or 75% were unruptured, and 36 or 25% had a ruptured tube at the time of surgery. When we looked at the adnexal mass appearance as compared to the rate of tubal rupture in these patients, it turns out that it didn't matter whether there was cardiac activity, a yolk sac, a tubal ring, an unspecified mass, or no mass at all. There was no statistically significant difference in the rate of rupture with any of these types of findings. We did note that the rate of rupture was significantly higher when the amount of fluid in the cul-de-sac was moderate to large as compared to small or none. However, we did note that moderate to large amounts of fluid had very poor sensitivity and poor predictive value. Well, what about HCG levels? Maybe that can help us tell whether the fallopian tube is ruptured or not. We had HCG levels available within 24 hours of surgery for 139 of our patients and found that there was no HCG cutoff level that we could use to predict tubal rupture. We noted that approximately 10% of our patients with low HCGs, or HCGs of under 500, had fallopian tube rupture at surgery. Here's two cases from our series. One side is ruptured, one side is not. And I know that you can appreciate that these are both well-defined tubal rings with a yolk sac in the center. Again, well-defined tubal rings, yolk sac in the center, really nothing different between the two cases. I will tell you that I put the rupture on the right because they both begin with R, but otherwise could not tell them apart. So, in conclusion, for tubal rupture is possible when there is no mass seen at all or when little or no free fluid is found. And there is no single appearance, including an intact tubal ring with a heartbeat, that can exclude fallopian tube rupture. And there is no lower level of HCG that excludes fallopian tube rupture. Just finishing up is the role of 3D imaging when you're attempting to make the diagnosis of an unusual ectopic. Don't forget to turn on the 3D and see if a rendered image might help you identify whether a pregnancy is located in a normal or abnormal location. It can be very useful to determine the difference between a tubal pregnancy, a cornual pregnancy, or just an asymmetric implantation. It can be useful in cervical implantations and with C-section implantations. Here's a patient with a retroverted uterus, fundus here, and you can see in the anterior portion of the lower uterine segment a large echogenic mass bulging the anterior contour of the uterus. And on the video clip, notice that there's a large gestational sac that extends up into the mid-portion, mid-body of the uterus, but yet also appears to involve the cesarean section scar. With color Doppler, we can see that there's quite a bit of flow to this implantation or early placental development area in the anterior lower uterine segment, so really no doubt that it's a C-section implantation. But look at the 3D rendered image. On the 3D rendered image, which we then rotate 90 degrees so that this is the anterior aspect of the uterus and this is the posterior aspect of the uterus, we can see that the gestational sac extends all the way out through the myometrium and that there's absence of myometrium from about here to all the way down to the cervix, and that the sac is completely splitting the serosa or the periphery of the myometrium. Here's a different patient who came in at 5 weeks, and there was a possibility of a C-section implantation raised on this first transvaginal ultrasound. And we can see that the region of a C-section scar would be down around here, but there's a pretty good myometrial thickness there. And here's the gestational sac, which does seem to be implanted quite low in the endometrial cavity, with all of this decidualized endometrium up by the fundus. A week later, with a question of C-section implantation has been resolved. Here's the 3D rendered image of the uterus with the gestational sac seen in the center. And when we rotate this uterus or this image 90 degrees, just as we did in the other one, we can see that the sac remains in the center of the uterine cavity. And here's again the anterior myometrial wall, and we can see that it is intact. And there's a little bit of V'ing here in the region of the C-section scar, but the pregnancy is in no way implanted in that scar. And again, the follow-up grayscale was just as diagnostic, with the sac starting to climb higher up into the uterus and myometrium preserved in the region of the C-section scar. What about cornual implantations? Can 3D rendering help us with cornuals? Here's the patient here's the transverse view of the uterus, and we can see no gestational sac in the uterus. But when we go way up to the fundus, you can see the gestational sac is off to the right side, and it's hard to know whether the myometrium is intact out here or whether it is not. Is this a little bit of myometrium coming out around the outside? Close-up image video here shows that this is a live pregnancy, and the issue again, whether this is a cornual / interstitial implantation or whether it is a normal eccentric implantation. Lots of flow around the gestational sac. When we push on the sac, you can see that it does not separate off from the uterus, but the answer really is clear on the rendered view, where we can see that the endometrial cavity ends and this gestational sac is sticking far out into the side. It is indeed an interstitial or cornual ectopic pregnancy, and the myometrium is not intact over the top of it. Another patient, 6.5 weeks, possibility of a cornual implantation. This patient has a divided endometrial cavity seen on the video clip, so either a septate or bicornuate uterus based on the grayscale, and the pregnancy way off at the right horn. On the 3D rendered view, we can see that we have a subseptate uterine configuration with a normal fundal contour. The endometrial cavity ends, and the gestational sac is seated way far out, and this is also a cornual implantation. Another patient with, again, nothing in the uterus, a gestational sac far out, this time on the left side, and then the 3D rendered image here, we see the gestational sac. Hard to know whether this is in or out of the uterus. And actually in this patient, back to the grayscale, we were able to slide, using that other technique of pushing, we were able to slide the ectopic off and separate away from the uterus. And this was an interstitial pregnancy in the interstitial portion of the fallopian tube, very close to the wall of the uterus, but not an intramural, not located within the cornua of the uterus. So a tubal pregnancy, but very, very close to the uterus. One last case of a pregnancy in an abnormal location. This is a transabdominal image of the uterus. We can see that the uterus is anteverted and the fundus of the uterus is here. A little bit of maternal bladder here, and an abnormally shaped, very oval, elongated gestational sac in the lower uterine segment. There was no cardiac activity seen, although we do have an embryo there. And this was read as a spontaneous abortion in progress. The covering OBGYN put in a speculum and pulled out the presumed impending or SAB in progress products of conception and sent the patient home. The patient returned several days later with copious amounts of vaginal bleeding, and here's the ultrasound. And you can see that distending the region of the cervix at the level of the C-section scar is a massive fluid collection with motion indicating that there is active blood moving in this area. So this was either an AV malformation or just a large area of retained products with a saccular aneurysm created with the retained products / accreta. Patient went to interventional radiology for bilateral uterine artery embolization, and following that procedure had an enormous hematoma here set at the level of the cesarean section scar. And you can see the hematoma here transversely, a little bit of flow to one area of it, presumably this piece, with a little bit of still viable tissue here. So an attempt was made to now evacuate under ultrasound guidance to evacuate that large hematoma. And we can see the catheter sitting up at the top of the fundus, right smack through the middle of all of this material, and the majority of this material was removed successfully at the time of the procedure. But we did note that on this transverse image that after the catheter, suction was applied, everything removed, and then a complex fluid collection would build up again, and then with suction collapse and then build up again. And this is clot or free bleeding that was still happening after the procedure. So the catheter was removed and a Bakri balloon was placed to tamponade this presumed uterine rupture where the C-section implantation had occurred. And this patient actually did quite well. After 24 hours, the balloon was removed. She stopped bleeding, and eventually the uterus did heal itself down in the region of the C-section scar. So be very careful with implantations that appear to be in the region of the C-section scar or in the region of a cervical pregnancy. And intervention is not indicated until the diagnosis is clear, and then with ultrasound guidance, with uterine artery embolization, and high consideration to injecting with KCl or methotrexate these abnormally situated pregnancies because of the high risk of bleeding. So in conclusion, transvaginal sonography continues to be the optimal method for the evaluation of ectopic pregnancy. Early diagnosis of ectopic pregnancy allows less invasive treatment options. When you're looking at a patient with a possible ectopic pregnancy, make sure you do a close evaluation of the endometrium, a close evaluation of the adnexa, try palpation, and try 3D. And most importantly, remember that follow-up imaging and HCG is the best management for a stable patient with pregnancy of unknown location. Thank you very much.